Good afternoon, everybody. Dr. Michael Jacobs here at the Fertility and IVF Center in Miami, and welcome to our weekly Monday midday chat on fertility topics. Today's topic is secondary infertility. How come it worked the first time but not now? Many of our patients get pregnant the first time, but then they desire additional pregnancy and find that they're having trouble. So, if you're not getting pregnant, you're infertile. The difference medically between primary and secondary infertility is just whether you've been pregnant before. So one of the most frustrating things for couples is infertility in the first place, but particularly patients that got pregnant once and then they're trying again and the second one just doesn't seem to be happening properly is a constant source of frustration and anger and why isn't it happening? What am I doing wrong? It worked the first time easily. So in looking at this, it's really no different than what happened the first time. The issue is, was the first time kind of lucky that there was a problem but it didn't show itself? Or has something new occurred between the first time you get pregnant and now that you're trying again? So the first thing that we do is sit down with the couple as a whole and try and get a really good medical history to find out what led up to the first pregnancy, how long did it take, were there any specific circumstances or issues involved. Two, has there been any intervening history between that birth or at the time of birth and present? Is there have periods changed? Were there complications of delivery? Were there retained placentas? Were there intervening miscarriages with surgical procedures? Is there something that would explain potentially a difference in what's happening? And obviously, how long you've been trying and what's been done so far to test as to why you're not getting pregnant. So the basic evaluation is pretty much the same. Sometimes we'll get an answer and we'll suspect something pretty easily just from history. Obviously, if a couple got pregnant the first time and then been trying for 2 or 3 years, and the male partner in the couple wasn't feeling totally up to stuff sexually and started taking some hormone replacements with some testosterone, testosterone supplementation or implants. Obviously, then we have to worry about, well, is that treatment affecting the ability to get pregnant quickly, basically? If on the female side, has there been anything obvious hormonally or anatomically? If periods aren't coming back, did you have an infection in the pelvis, or did you have treatment for some other disease or disorder, or any intervening surgery? We can often get the answer. So in essence, it comes down to going back to basics. And the back to basics to find out why it's not happening is to look at, on the male side, again, the main key thing is the semen analysis. We look at the count, motility, and morphology of the sperm. And even men that have very low sperm counts, if you did a sperm count once a month for 2 years, occasionally you might find a good day. And if a couple was trying to get pregnant and they got pregnant the first time around, it doesn't mean that the sperm are definitely okay just because it worked 2 years ago or 3 years ago. It's more likely going to be fine than not fine, but until you test it, you just don't know. So on the male side, we do a sperm count. Are we looking good, or is there an issue that we need to deal with? On the female side, it comes down to answering the questions for the three basic things that we always look at. One is, are you ovulating properly or not? If you have a regular cycle, that's every 25 to 34 days, that doesn't mean you're ovulating, but it's more likely that you are. If you have a regular cycle and you've done home ovulation tests, these ovulation predictor kits or basal body temperature charting, and either of those suggests that you're ovulating in the middle of the cycle by showing a thermogenic rise in the temperature on the temperature charts, or by showing a color surge on the ovulation predictor kits. The combination of either of those two measures, the OPKs, the ovulation predictor kits, or the temperature chart rising, in conjunction with a regular cycle, are pretty good evidence that ovulation is occurring. We can get a progesterone level around the 20th, 22nd day, and that confirms ovulation takes place, and it's the hormone the ovary makes after ovulation does occur. The second question is, are you still making good eggs? And some of that is age dependent, and we can get an assessment of the quality of the eggs that may be in the ovaries a couple of different ways. One is to ask someone how old they are, and obviously if somebody had a first child very easily at age 38 and now they've waited 5 or 6 years and they're 44 or 45, more than likely we're going to find that the ovarian reserve is markedly reduced and age is becoming a major factor. This is much less so the case if you have somebody who's 30 and then at age 34 decides to have another child. So understanding somebody's age and the association of egg quality with age. The second part of aging is both the number of eggs that are present is much less, the quality of the eggs is much less, and when these eggs are fertilized, the natural incidence of forming abnormal embryos is much higher. So the aneuploidy rate goes up as you get older. So patients, as they increase in age, have a more difficult time getting pregnant and staying pregnant. People can still get pregnant with poor quality eggs, basically a poor ovarian reserve. You just need one egg to fertilize, resulting in a genetically normal embryo, and that gives you a good chance of getting pregnant. What we do to treat you might change depending on age and these tests. So, one is ovulation. Second is measuring ovarian reserve. Ovarian reserve, to review, is measured by asking you how old you are, doing some blood tests for AMH, which is the anti-Müllerian hormone, and also often FSH and estrogen on the second or third day of the cycle. And lastly, by doing an ultrasound early in the cycle, we can both measure the number of little black lakes in the ovary called the antral follicles where the eggs live, and the ovarian volume. And those things will correlate with ovarian responsiveness to fertility drugs. So patients who have good ovarian reserve, as evidenced by lots of antral follicles on ultrasound, as evidenced by a low FSH and a acceptable AMH level, are more likely to do better than patients who don't. And the third aspect on the female side is the anatomy. And that's just to make sure that the uterus is normal and the tubes are open. Regular surgical intervention for like a cesarean delivery or a D&C for a miscarriage, unless they're complicated by infection, they usually don't cause infertility. It's possible to form scar tissue from these procedures, either in the uterus or around the tubes, but it's unlikely to. So if you had a C-section, you haven't had any complications and everything is fine, more than likely you're okay. But we do want to confirm that, and the way we confirm it is by doing a hysterosalpingogram. And hysterosalpingogram is a radiologic test where the radiologist will inject an opaque iodine-based solution, basically a clear solution, but that into the cervix, and take a picture of that solution as it fills the uterus and goes out the tubes. And that tells us that the anatomy of the uterus is acceptable and that both tubes are open, basically. So, the key ingredients, obviously, we need sperm. On the female side, we need eggs that are ovulating. We need good eggs, good ovarian reserve, and good eggs to start with, and we need normal anatomy to work with. So that's the diagnostic part of what we do. The next part is obviously, when do we start treating people and how quickly do we intervene? And part of this depends on their history. in a couple that got pregnant quickly the first time, and it's like starting out fresh. If we have a couple that had a hard time the first time, it took them 3 or 4 years to get pregnant. There was some particular finding, either the tubes weren't working, one tube was blocked, you didn't ovulate regularly, the sperm count was a little bit abnormal, or a combination of these things, then we may want to intervene sooner than not. Again, if a couple's under 35 on the female side and everything is normal, you want to wait at least 9 to 12 months before doing anything, give nature a chance for pregnancy to establish itself. In women that are over 35, we say 6 months, only because we have less time to work with, and you want to intervene a little bit sooner. And certainly, if a couple is very antsy for whatever reason, we can certainly kind of speed things along and do some fertility augmenting procedures. But the treatment, first of all, is fixing what's broke, and that's why the basic evaluation is the best way to start. If we can improve a sperm count that's not normal, terrific. On the female side, use of vitamin supplements is sometimes helpful for diminished ovarian reserve, but it's a supplemental approach. It's not a treatment for it per se. So doing that alone and waiting usually doesn't work, but doing that in conjunction with other things that we're doing makes sense. Obviously, if a tube is blocked or not working properly, or has scar tissue hiding somewhere, then the options are either to bypass that tube or to consider doing surgery to repair the tube. And if everything is unexplained, meaning that there's good sperm, ovulation's occurring, the tubes are open, then we want to use some fertility enhancing techniques. And the two approaches there are to consider the use of either ovulation induction with a fertility drug combined with intrauterine insemination, or the use of in vitro fertilization. So if we kind of look at things stepwise, again, first thing is, well, let's find what's wrong. If we can fix it, terrific. If everything is relatively normal and we're dealing with unexplained infertility, or we're dealing with some mild sperm factors, the count's a little bit low, the motility is a little bit low, morphology is low, but everything else is normal, we've got kind of unexplained infertility. Certainly if ovulation is not happening properly, then use of an ovulatory drug is the best way to go. So if the cycles are all mixed up, if ovulation is not happening properly, we use some fertility drugs to help people get pregnant. They're better called ovulatory drugs. The oral ones are Clomid and Letrozole or Femara, and the injectable ones are Gonal-F, Follistin, and Menopur. We usually use oral medications first, most often, if not pregnant within the first couple of cycles, or we have a contributing male factor with low motility or low morphology of the sperm, then we'll combine that with insemination to just get things to happen quicker. And from the standpoint of the quicker we can get you pregnant, the less frustrating it is, the less aggravating it is, less expensive it is, and our goal is to get you a healthy pregnancy, a healthy baby in a time-efficient manner, so that the frustrations of treatment and infertility are minimized as best possible. So ovulation induction with timed insemination is nothing more than using an oral ovulatory drug to optimize ovulation. It also gives us the timing of when the egg is developing, so that we can give you a medication that will cause the egg to ovulate within a certain 12-hour window, so we know that's a time period where you either need to have timed relations, or we can consider doing insemination depending on the circumstance. If that's not working, or there's tubal disease, or the sperm counts are very, very low, then IVF may be the better approach sooner rather than later. And the reason is that it bypasses everything. It bypasses the sperm and egg finding each other. It bypasses the sperm fertilizing the egg, because we perform intracytoplasmic sperm injection, or ICSI, to get the eggs to fertilize. It bypasses the need for the tube to transport the embryo back to the uterus, because the embryos are formed in the dish, and then 5 days later transferred back into the uterus. It gets around some of the issues of aneuploidy because although we cannot change an embryo, it is what it is. We can't go in there and remove an extra chromosome and fix a chromosome. We can't repair anything at this point. But if we have a group of embryos to choose from, and we're doing IVF, we can do pre-implantation genetic testing to see whether that embryo is normal or not, and selectively choose what is the euploid or the normal embryo to put back in. And for those that were with us last week and the week before, already know that with pre-implantation genetic testing, you also get the added benefit of assessing whether that embryo is male or female. So if you want a family balance, sex select, you can, obviously, assuming we have both embryos. So the only thing that we don't know, that we don't have any control over with IVF really is the implantation process. Will the embryo stick or not? And it's frustrating because even with normal embryos, half of them will stick and half of them won't. But that's a whole lot better than anything else we can do. So, if we're looking at secondary infertility, we need to find out what's wrong. Male, semen analysis; female, ovarian reserve testing, checking the tubes and uterus. Ultrasound is great for knowing there are no fibroids or anything major there, but you need the tubal dye study to see if the tube is open. Ovulation, we usually know pretty much from history and ovulation kits. And then it's just a matter of, okay, do we just sit tight? Do we give nature some more time on its own? Or do we intervene? And if we intervene, do we intervene in a stepwise fashion because it's sort of unexplained? Or do we intervene in a more direct fashion with something like in vitro fertilization? And that would depend on the couple's desires, first of all. Second would be what the cause of infertility is. If you have tubal disease or severe male factor, IVF sooner makes a whole lot more sense. And three, if there's diminished ovarian reserve, although we can go stepwise, often taking advantage of IVF sooner is better because you get more embryos. And if you particularly want additional children, having some extra embryos available potentially it markedly increases success rates down the road when you're older. A couple questions. This is just what I was talking about. One of the questions is if we, let's say someone goes through a cycle and didn't get pregnant and they have one embryo left, and the question is, do they transfer that last embryo or do they go back and get some more eggs to sort of stockpile the embryos? First, it's important to make sure that if we're going to do that, it's a good idea to make sure the embryos were biopsied to make sure they're normal embryos, so we're not storing embryos long term that don't have a chance of working. So our best advice at that point would be to do pre-implantation genetic testing. If the feeling is that the couple just wants one child and there's one embryo left, there's no advantage of being put back on injectable fertility drugs to get more eggs because it's just one embryo. And if it works, then you've got your family that you want and you're done. And you don't have to pay for storage of embryos long term, and you don't have to pay the extra cost of having more fertility drugs and going through an IVF cycle. However, if you think of this logically, if someone is 39 or 40 years old and they have one embryo to work with, and that could be one embryo because there was only one normal embryo, period, or there's one embryo because there might have been three and you used two of them and there's just one left. The question is, am I better off transferring that embryo or should I batch the embryos? We call it batching because we're just adding to the pile that are in the lab. The answer to the question is, what are you planning to do down the road? Is this one child or two? If you want to have an additional child 2 or 3 years from now, and you're still working on getting this one, let's say we're successful with that one embryo, and you're 39. You're going to deliver 9 months from now, and then you're going to have to wait 3 to 6 months before you can get pregnant again. So now you're already almost 41 and a half or 42 when you're trying to get pregnant again. And in most patients in that age window, their fertility is going to be a lot better at 39 than at 42, and a lot better at 40 certainly than 43 or 44. But if you look at couples where, they're 25 and they go next child will be at 28 or 29, probably doesn't matter. But when you get up in the older part of the reproductive age window, in your late 30s, and particularly once you get close to the 40 and above, I would say anybody in that age range that wants to have more than one child and has only one embryo of good quality left is better off stockpiling embryos or batching them, because their ability to produce good quality embryos is only going to decline as they get older. So doing kind of having an idea of fertility preservation while at the same time trying to get pregnant is a great way to come from. So I think it's a great question and a great way to think of things. If we have somebody who's had multiple embryos that don't stick, multiple embryo transfers that don't stick, it brings up the question of should any additional testing be done beyond just testing for fertility issues. And we usually have that conversation after 2 transfers with genetically normal embryos or a past history of miscarriage, whether we test for implantation failure assessment as well. Why would multiple GS tested embryos? So the reasons why embryos don't implant, basically, why don't embryos implant? It's a great question, particularly if they're normal embryos. The first thing you think of is the uterus okay. The only thing you can do with the uterus is look at it on ultrasound, examine it clinically, and look at the inside of the cavity on hysteroscopy. So we do all those things. And then you get into the concept of, is a failed embryo really just a very, very early miscarriage? We don't know if it implanted for a couple of days and then miscarried or not, because the reality is after an embryo is put back in, we can't test anything for 9 days. So the embryo is going to grow or not grow at that point. Most of the time we're pretty sure we put it in the right spot with IVF because we're doing it under ultrasound guidance, and even when you can't visualize things that well, we know the length of the cavity and where the catheter is just from previous assessments. From that standpoint, we look at a couple different things that we don't normally test for. One is to look for the presence of anticardiolipin antibody and lupus anticoagulant. The latter is not a test for systemic lupus disease, but we test for antiphospholipid membranes in the form of anticardiolipin antibodies. We test for thrombotic abnormalities with lupus anticoagulant and beta-2 glycoprotein levels. Sometimes we do additional clotting studies. And the third is to measure part of the immune system called the natural killer cell system. And this part of the immune system usually works in your favor to get rid of bad cells. But the concept is if it's overly active, maybe it's reacting with an embryo as a foreign entity to try and get rid of it. If those are all normal, then there's one other thing that we'll often bring up to discuss. We don't do it very commonly, though, is testing for what's called endometrial receptivity, with the concept that we know there's a small window of implantation when a healthy embryo will stick into a healthy uterus. And for most people, it's very predictable, related to the timing of when you start the progesterone in a programmed embryo transfer and when you put the embryo back in. There's probably a subset of patients who, despite being on a typical dose of medication that's well understood, have sort of an atypical response to it and don't do what they're supposed to do. They're taking the medications okay, but the lining of the uterus on a molecular level just isn't transforming itself naturally. And if you look at patients that have failed at least 2 cycles, who've had endometrial biopsies, some of them will find that if you measure all the different enzymes that are turned on and the proteins that are produced at that point, you can tell whether we need to shift the timing of the transfer forward or back by 12 or 24 hours relative to how much progesterone you're taking. The problem is it's sort of an experimental test. We have to do a mock embryo transfer cycle, biopsy the endometrium, and send the tissue off to a special laboratory in Spain to analyze it. So it's a test that costs a couple of $1,000 rather than just a couple of $100 when you add it all up. So we don't do that very often. We have done it in some cases. In some cases, it makes a difference by changing things. In some cases, it reassures us that we're doing things correctly. And in some cases, we change things based on what it says, and we end up with the same outcome. So those are the things that your doctor will talk to you about: the failed implantation testing, and in some cases, endometrial receptivity assay. We do a lot of the basic stuff when embryos don't work. We don't do a whole lot of ERA assay testing just because of the expense involved with it. A final note, because someone brought up the question, is are we doing any studies basically? We do have a present IVF study with one of the drug companies looking at a different formulation of an injectable fertility drug called Menopur. Menopur, or HMG, has been used to stimulate ovaries to produce multiple eggs for IVF for over 30 years. They took the powdered form of the medication and turned it into a pre-diluted liquid and use it in a pen device to deliver it, instead of having to mix the powder with the water, draw it up in a syringe, then inject it, and so forth. So they took a very cumbersome way of using medication and made it really simple. The problem is that because it's a new formulation of an existing drug, it still requires FDA approval to show that there's no difference in efficacy of that medication to the one that's already being used. So we presently are involved in a 19-center clinical study with 19 other fertility centers. We're the only one in South Florida participating in it. And patients who qualify for this study do get a free cycle of IVF treatment because the pharmaceutical company is paying for that study of treatment. We're very limited on how many people we can put into it each month, and we have some people on a waiting list now, and you have to meet very strict criteria related to age, weight, FSH level, anti-Müllerian hormone level, uterine integrity, sperm counts, and so forth. But if IVF is a treatment that makes sense medically for you and finances have precluded that from taking place, please bring up the possibility. It's called the CLARA, C-L-A-R-A study, and we're more than happy to try and get as many of our patients into the study as we can. Again, we have an allotment each month, and we're now recruiting for our, we're filling our September spots, probably with some people on our wait list. But if you're interested in that, please call the office, let them know you're interested in the IVF study or the CLARA study, and we'll go through the chart and make sure you're a candidate, and if you are, do our best to get you into it. And that's pretty much the whole story for today. So I thank everybody for tuning in. I thank you for the questions. I very much thank people for the words of support, and I can't tell you how great it makes me feel when someone says that I was the best doctor, or we helped them get pregnant, and 23 years later their embryo is now graduated college and having their own life. And one of my friends who used IVF many years ago to get pregnant, that the baby that resulted from that IVF cycle is now pregnant with her own child naturally. And so other than the fact that I'm getting old, it feels great to know that we've made a big difference in people's lives. So thank you all for your kind support and words, and certainly let your friends know. And pretty much Mondays at 12:30, I'll come on and talk about something and try and address people's questions. And we're here to help you and provide good medical care and get you that family that you so much deserve and want. So take care, stay safe, and see you next week, guys.